Thanks for joining us. I'm your host, Raquel Faria. I'm a doctor of internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I will be discussing some more challenging lupus cases with Professors David Isenberg and Murray Urowitz from the Lupus Academy Steering Committee. David and Murray, welcome and thank you so much for joining us today. Let's discuss the cases. So, David, this first case is from your clinic from about 3 decades ago. Let's take a look at some background. In the mid-1980s, a 31-year-old teacher, originally from Ireland, was diagnosed with systemic lupus erythematosus based on a classic lupus butterfly rash, persistent polyarthritis, mouth ulcers, and mild thrombocytopenia. She was treated with corticosteroids, hydroxychloroquine, and methotrexate. During the following 3 years, she stopped smoking. She fled several times, and both corticosteroids, hydroxychloroquine, and methotrexate were adjusted during flares. She presented in 1987, 6 years after the follow-up. She had pain, seemingly going down her left arm, and the junior doctor who reviewed her initially was perplexed. There were no other symptoms. The junior doctor presented her to you, David, saying that movements of the arm itself seemed normal, including movements of the cervical spine seeming normal, and neurologically, there were no other abnormalities, neither sensory or motor function in either arms. David, you reviewed the case with the junior doctor, and what did you see?
So Martin Richter, who was then our senior registrar at the time, called me in to see this patient and said he was very puzzled. He couldn't find any obvious localizing signs, and yet the patient was complaining of pain going down the arm. And on examination, I indeed looked at her shoulder, her elbow, her arm. It all seemed pretty normal. Looked at the cervical spine. That seemed very normal. So it was very hard to determine what this was all about. She's a relatively young woman, and I don't know if you want me to go on to tell the story about what happened next day, because it was very shocking.
Yes.
And, I'm sure we've all had experiences like this, and some patients live with you for many decades afterwards, and you're thinking, could I have changed things? It was very, very shocking to me the following day when her husband called me to say that his wife had died. There was a post-mortem, and she was found to have had a myocardial infarct. She was found to have 3-vessel disease, quite profound and significant atherosclerosis, and it was really quite shocking. Now, by that time, and Murray may well enlighten us about how he kind of came to this, some very sterling, brilliant work done by Murray and Daphne Gladman had reminded us, or taught us actually, that actually lupus patients were more prone to developing atherosclerosis. And the work of Sue Manzi a little bit after this event confirmed that if you are a woman and you've got lupus and you're between 35 and 44, your chances of having a heart attack are increased by 50 times. And this that sort of figure has sort of stuck with me for many years subsequently, but obviously was not available at the time that I saw this patient, although Murray's paper had warned us that this was a risk. And this was the patient who really brought home the risk to me, that just how important it is to think about atherosclerosis in the context of lupus. And I guess Murray, sorry, I'm taking a role working, but Murray.
David, this is obviously a tragic case, and the thing that also puzzled me, so it happened already 30 years ago, is that she only, and I'm doing this only between commas, had 6 years of SLE evolution. So, and can you dissect a little bit more about What were the
So
doses of steroids?
So I should say I had a long discussion with her husband, and I really pushed her. Surely she must have had some chest pain. She must have had some shortness of breath. And he recalled an episode. I think she'd been walking up a hill about 3 months before, and she had seemed a little short of breath, but it seemed to have been a one-off thing. Obviously, we had checked her lipid levels, and I think her low-density lipoprotein was a little bit high. Her total cholesterol was a little bit high, not perhaps sensationally so. She certainly wasn't on statins or anything like that. Her husband confirmed that she'd been a smoker. She'd probably started in her early teens. So by the time she died, she'd probably been smoking for close to 20 years, actually, although she had stopped some years into her post her lupus diagnosis. But she probably had a good 15 years plus, and he suspected she'd probably been quite a heavy smoker, although as I say she'd stopped about 3 years before. We looked at the family history. From memory, there wasn't very much to indicate that this was that myocardial infarcts were a major or even any kind of vascular problem was a big issue within the family. But clearly you don't get, I think, myocardial infarcts in lupus patients necessarily just because of the lupus activity per se, but you have to look at the adjunctive factors. I'm sure we'll come on to those, but clearly smoking is one, antiphospholipid antibodies are another one. She didn't have those, actually. So we did look very hard to see what other underlying factors might be there, and smoking did seem to be the big thing. And as you say, between 6 or 7 years of a fairly persistent active lupus. Yeah. I think that probably was important.
Murray, what particular questions do you have on this lady's risk factor for myocardial infarction, both related and unrelated to lupus? And what do you think about this perplexity of mine that she only had 6 years of lupus?
Right. So there are two things that I want to bring up. First, David, her blood pressure, because, there's been this new recent redefinition of normal blood pressures, not 140/90, but 130/80. And we've shown in a study that the people who run between 130 140, those just above the current recommendations and above 80 to 90, they have an increased prevalence of atherosclerotic events. So, she was in an era when we were still using 140/90, and it would be very important to know what her blood pressure was at that time. Was it being controlled? Was it controlled?
Yes, I'm afraid I can't remember at the top of my head. It would be relatively easy to go back and check that, but you're probably right. It probably was just that little bit higher than we would be happy with now, but at the time it didn't seem such a worry. But I suspect that's a very good point, and I will check that out of interest.
Right. So that's one additional risk factor. The other thing is, and Raquel, you were intimating something when you said she only had 6 years of lupus. Well, we've reported in the SLIC study, and David was part of this, is that we had in our patients with lupus in the SLIC study, we found that 23 patients had lupus, had their atherosclerotic event either before lupus or within the first 2 years of lupus. And there were 23 such patients. 16 of it had it before the lupus, with a mean of 6 years before the lupus. And then 6 of them had it within the first 2 years. So the duration of lupus was not significant in those patients. And so you wonder, does that mean that the predisposition to lupus runs congruently with the predisposition to atherosclerosis, and maybe you don't need lupus to get atherosclerosis? Because here you had 23 patients who had virtually no lupus that was diagnosed at the time. So I think it occurs early, or even before. So, the American Heart Association, American College of Cardiology now have said that if a woman in her 40s comes in with a myocardial infarction, you should work her up for connective tissue disease, especially lupus. So I think I think the blood pressure will be important, and the fact that she only had it for 6 years is not unusual. And As a matter of fact, David's case here, my first case where we first described the bimodal mortality was similar to almost the same. And she was 42 years old, and we never suspected that she would have a myocardial infarction at that time. So it rang a bell when David told that story about having it early.
And what do you think about the risk factors related to lupus? So what are the main risk factors, beside controlling all the others, that might induce an accelerated atherosclerosis?
Well, but Murray should tell us about the fantastic work that he's done both within the SLIC group and also in the context of his own cohort, showing that if you can bring lupus active disease under control faster and better for longer terms, your outcomes begin to show improvement. And Murray, you've already shown some of that data. So you might want to comment on that.
Yeah, it's well, we came upon it very fortuitously. Everybody had said, gee, if you have a cohort of patients with lupus, about somewhere around 13% or so are going to have a myocardial infarction. And everybody believed that. And then in the SLIC cohort that David was talking about, this was an inception cohort, started in 1999, so the modern era. And when we looked at the risk factors that were there and their mortality, there was a dramatic finding. The finding was, no, it's not 13%, it's around 3 or 4%. And we didn't believe that. We said, how could there be such discrepancy? And so what we did is we looked at our cohort between 75 and 90 approximately. That was the old days. And then we looked at the modern era from 99 to 2011, which is the era of the SLIC cohort. And oh my God, we found the same thing. In the new cohort, the prevalence of an atherosclerotic event was around 3 to 4%, as opposed to 13%. Whereas in our old cohort, 75 to 95, it was around 13%. So what's happened in the modern era is we're getting much better. And when we looked at our cohort, and David already suggested all of this, the new cohort, from 99 to 2011, and then followed for 15 years after that, in the new cohort, the risk factors, the classic risk factors, all being better controlled, mainly because we were aware of them. And second of all, the lupus was being better controlled, almost certainly because we've got new medicines, or we have a better idea of how to treat lupus. So treating the inflammatory disease is crucial, and if you do both, you really try to get people under control earlier, and we could talk about that early treatment, and also look at the risk factors and treat those. I think that's what's resulting in better outcomes, and I think we'll continue to do that if we really focus in on those issues.
And less steroids.
Oh, yes. So by controlling the disease, not on steroids, because steroids are the culprits that give you the risk factors, right? They increase your blood pressure, your cholesterol, and induce diabetes. So they induce all the risk factors. So control the disease better without using a lot of steroids.
So, David, if she presented, like we talking about the new era, if she presented with their initial clinical picture currently, what tools would you have to prevent this kind of events?
Okay, so I think I'd like to highlight some beautiful work that's been done by my colleague Alistair Rahman, recently confirmed by Maria Tsektonidou in Europe, or in continental Europe, I should say. Alistair did a very nice study in which, together with a fellow Portuguese colleague of yours, Sarah
Croca.
Yeah, exactly, Sarah Croca. So they took 100 asymptomatic lupus patients, and they did very sophisticated carotid and femoral scans, ultrasound scans. Remember, these patients have no features of suggesting of clinical atherosclerotic disease. To their surprise, they found that in a third of these patients, there were significant plaques, a third. They then followed these patients up for another 5 years, and they've rescanned about 70 of them. And I know we have colleagues now in the UK and London who are writing this data up, but I don't think I'm going to reveal too many dark secrets by telling you, surprise, surprise, none of those plaques got any better. And guess what? Virtually they all got worse. And we've had events. We've had myocardial infarcts. We've had strokes. So you can pick these up with carotid and femoral ultrasound scans. So you can identify patients who are at even greater risk than perhaps some of the other patients. Certainly for these sort of patients, what we're now doing is we're trying to, it's funny if you have this conversation today, because just last week we're discussing within the unit, maybe we should employ, it'll probably be a nurse, to do a kind of a check on a number of peripheral but very important aspects of lupus, of which clearly atherosclerotic risk is one. And this nurse will be employed specifically to look at things like osteoporosis risk, atherosclerosis risk, possibly malignancy risk. And we're going to do it very as thoroughly as we can do, including carotid and femoral scans, fasting lipids, checking on steroid doses, because clearly we want to be as effective as we can be. And although Murray's, of course, absolutely right that controlling the disease activity remains pretty pivotal, nevertheless, there will be patients with very strong family histories. About 4 or 5% of our patients with lupus are diabetic. We know that those patients are going to more likely to have atherosclerotic problems. So there's a lot more that we can do that we feel we need to sort of focus on just a little bit harder than we have been doing.
Murray, do you have any additional comments on the tools to screen for atherosclerosis?
Yeah, what I'd like to do is stress what David has said. I think we have to work this into our armamentarium, and we've tried to do that now. And that means checking all of the atherosclerotic classic risk factors, but even employing more sophisticated and carotid scanning is certainly one. We've shown that myocardial perfusion studies are abnormal in a quarter to a third of patients who have absolutely no symptoms at all of this. So, it depends on what your center is able to do, either a carotid scan or a myocardial perfusion, or even the brachial artery dilatation study, which measures a similar kind of vascular outcome. Whatever the center is able to do, you should institute one of those as a regular screening test in patients with lupus. Just like we do follow-ups for their lupus, we should incorporate follow-up for atherosclerosis into their care.
Thank you. And can I just give you a challenge, an additional challenge? This patient had arthritis, mainly arthritis as an involvement of activity of lupus.
Correct.
And if the patient presented now, what kind of treatment would you use, David? She was on methotrexate, which we still use, and it's very good for arthritis, even in lupus. But would you have done anything different if she presented currently?
Well, this is not going to come as a great surprise to you, Raquel. We now give our patients a choice. We say to them, look, you can have the conventional treatment, which will be low-dose steroids, methotrexate, or we will treat you with B-cell depletion. And we've been using rituximab now for 25 years in our center. And we have a number of patients, it's around 30 now, who have said, yeah, they'd like to try that right from the start. And the aim here is to try to treat them without using any oral steroids. And as we were discussing just before we came on air, I've just done a lupus clinic, and I saw in one of the patients, the very first patients that we treated many, many years ago, who has not had any steroids, none. I mean, no oral steroids at all. And her disease is pretty well controlled. She was for some years on low-dose mecafenolate and hydroxychloroquine. She's now down to hydroxychloroquine, no oral steroids. And so it is possible to do that. And Liz Lightstone has done the same sort of work in lupus nephritis patients, showing that you can treat lupus nephritis with patients without using oral steroids. So yeah, so that's the big change in our department, that we now offer patients a chance for a steroid-free form of treatment. Now, not every case does it work, and in some cases you get an allergic response, because sadly, as you know, 20% of rituximab remains mouse protein. But I think that's going to change. We've discussed it in previous topics in these podcasts, as drugs like obinutuzumab become available, because they are 100% fully humanized. So that should solve the problem that we got with some patients. In the 212, I think it is, lupus patients that I've treated with rituximab, I've got a cohort of about 20 where it works beautifully but I can't give it to them because they become allergic. So I'm looking forward to the day when hopefully obinutuzumab or some other linked drug is approved, and then that we should get around that.
Mary, what would be your choice to treat this lady, and how early is the early treatment that you mentioned before?
Yeah, so that's an important question. I think if she came in with mainly mainly joints, I think I would have started with hydroxychloroquine, a small dose of steroid. Excuse me, David. I still try to get people off by 6 months, and I think if I can do that, I'm fine. But small dose, so hydroxychloroquine and steroid, and I think methotrexate was fine. But it sounds like this woman didn't have a good response, right? In other words, she kept coming back and being readjusted, etc. I would have switched her very early to, well, one of the other therapies. Probably at this time, at this era, I would use belimumab, which has been very successful. And now we have more than 10 years of toxicity behind us, lack of toxicity behind us. So I think I would have gone to that early.
Thank you. And I think you mentioned a particular point that is sometimes one of the inertia in the outpatients clinic is you start methotrexate, you try to optimize methotrexate, and the patient is not quite responding. Should we just increase dose, switch to subcutaneous, or how long should we do it? Are we going to use the timings of rheumatoid arthritis? What are your insights about how early to switch?
Well, my philosophy with the patients in whom I start methotrexate, and I do use it, and it is quite a good drug, I think. It's to say to the patient, look, I'm going to give this to you for a trial, perhaps 3 to 4 months, and we'll give it in 15 to 20 milligrams per week. That's the usual sort of dose we would go for. If I got a decent response at 15 milligrams, but the patient says still not quite as good as I'd like it to be, I would say, well, we can go up. That's okay. I find that going up above 20, in my experience, relatively infrequently buys you a great deal more benefit. So I think if it's going to work, it's going to work by about 20 milligrams per week. If it hasn't worked by 20 milligrams per week, with 1 or 2 patients, I've tried a little bit higher. I've never been that impressed that I've done a good thing for the patient. So in those sort of circumstances, do it as a trial, see if it works after about 4 months. If it has, all well and good. If it hasn't, well, you tried it. And then, as Murray said, it's either benlysta time or rituximab time.
Murray, 6 months, 12 months, 9 months? How long would you wait?
For joints, 3 to 4 months.
Okay.
I think. And, well, we'll talk about that later maybe, but for other conditions, 0 months. And I'll discuss that, I think in general now, we recognize that we get better results when we start early and do multiple drug rather than, additive approaches here, where you add a drug 3 months later, give it another 3, 4 months, add another drug. I don't believe that. I really think we got to put this out as early as possible.
Thank you so much. Let's just jump to the other case. Murray, this time the case is from your clinic. So this 34-year-old Bangladeshi female cook, she presented initially with a 2-month history of increasing fatigue, new mouth ulcers in the previous month, and new pain and swelling on the proximal interphalangeal joints in both hands. Labs revealed positive ANA with pretty high titer, anti-Smith antibodies, anti-dsDNA antibodies, and her hemoglobin was 10.5. The other tests were unremarkable. On the follow-up visit, she started on hydroxychloroquine and prednisolone 15 milligrams a day. Her mouth ulcers were reduced, her arthritis was still there, but easier during this period. But instead of feeling better, she was feeling increasingly tired over the next 4 weeks and developed loss of appetite and nausea. And the labs were reevaluated and showed 3+ proteinuria with more than 30 red cell casts, and the 24 urine collection showed 2.38 grams of proteinuria a day. A blood pressure and creatinine were normal, but the hemoglobin fell to 9.5, and the COMS test was now positive, with slightly raised bilirubin. The prednisolone was increased to 30 milligrams a day, and after 8 weeks of follow-up, it helped with some points, but it didn't resolve the fatigue, the nausea, and the anorexia. The mouth ulcers disappear within a week of the increased dose of prednisolone, and she was not feeling anymore the swelling and pain on her fingers. But now the blood tests where the hemoglobin was 11.2, the positive COMS test was now negative, and the urine dipstick still had 3 crosses with the red cell casts evident on the sediment analysis. And she repeated the 24-hour proteinuria, and it was still 1.79 grams per day, and the creatinine was slightly elevated. Murray, can you please tell us about what you did interpret as you were going through this patient, and what do you think is the next step?
Oh, I'm so embarrassed. So this is this is the old days where we plodded along, unfortunately. So when she first presented to us, she presented with clinical findings. We drew some blood tests and had her come back, and we started her on some treatment. When she came back and she wasn't very much better, then we did a more thorough study and found this time that she had proteinuria. It's not that we didn't check it the first time, but over the 3 or 4 months interval, she developed proteinuria. This is a point to remember, that lupus nephritis may not be there at visit 1, but can appear within the first 6 months or so, supposedly out of the blue. So she now has very significant proteinuria. And, it was at this time that we increased the steroid further, and she's on hydroxychloroquine. And this is the time that we ordered the renal biopsy. Would I do things differently now? Absolutely, I would. I would have got the biopsy earlier, and if it showed what it showed here, I would have been much more aggressive in my therapy than I was.
David, we're just going to the results of the biopsy, but I have some additional questions for you. If this lady presented on the current times, is there any biomarker that is available now that was not available at the time that you would add to the blood and urine to have a baseline of the patient before this involvement?
Well, Raquel, this is a very hot topic, and the ones which we've used for many, many years are somewhat deficient, and I'll explain why. Antibodies to DNA amongst the lupus autoantibodies that we regularly measure are the ones which are most closely associated with renal disease. And I based that in part on a study that I did with the late Mo Reiklin some years ago, where Mo Reiklin was a very brilliant guy and developed these super sensitive assays. And we measured antibodies to DNA and SM and RMP and Rho and LA and histones. And we looked at 7 serial bleeds on 15 of our black lupus patients. And the absolute standout, the strongest correlation with renal disease was antibodies to DNA. Now, problem is that at least a third of the patients in our cohort, most cohorts, don't have antibodies to DNA. So that's a bit of a problem, not least because, as others have shown, you can actually detect a number of other autoantibodies in tissue biopsies from lupus patients. You can find antibodies to Rho. Peter Mallison showed that many years ago. You can find antibodies to SM. You can find antiphospholipid antibodies. So although antibodies to DNA are highly likely to be responsible or strongly linked to the development of renal disease, that's not the only answer. Antibodies to C1q are now widely available, and they have, again, a strong correlation with lupus nephritis. A low C3 is often associated with lupus nephritis, but again, in our hands, at least 50% of lupus patients don't have a low C3. So people have looked to see both in the blood and in the urine whether there are better markers, and people have identified or studied very hard to look at a whole huge variety of cytokines, cell adhesion molecules, chemokines, and some favorites have emerged. There's the delightfully named tweak molecule, which you can find in the urine of some patients. There's another one called, I think it's MCP1, which I think I'm right in saying is a soluble CD marker. It's 163, something like that. But the trouble is that so far, none of these experimentally looking quite interesting molecules have really made it into the commercial world. Nobody seems, that I'm aware, we certainly don't have it available in the UK, to, if you like, taken a chance on developing a widely available tweak assay or a widely available IL-6 assay or IL-8 assay or other things like anti-inlays, for example, alpha inlays has been measured. You can measure BAFF levels, and there's some correlation between BAFF and lupus nephritis as well. But there is a huge panoply of molecules which have been discussed in this context. But my knowledge, anyway, and you and Murray may have other views, nothing really has become commercialized to the extent that it's readily available for us to use in the clinic yet. And I think that is a shame, because there is a gap in the market which has not been filled.
Murray, do you want to add anything on this particular question before getting paid?
Yeah, I do. I think it's important here. I think a marker, a liquid biopsy, so to speak, is crucial, and we're getting closer, as David said. And you've picked the one with the CD163, which is the one that really most people feel is the most promising. But it doesn't take the place of the first biopsy, at least, right? Because the first biopsy is going to show you the extent of the involvement, the tubular interstitial inflammation as well, and the arterial involvement. And so she needed this biopsy. Now, once you've got the initial biopsy and you see that she has primarily an active glomerular disease, down the line, if she doesn't respond, if there was a really good liquid biopsy, that would be the time to think about it. The first biopsy is crucial and should not yet be done away with, So she had the biopsy, and as you...
So the kidney biopsy confirmed a type 4 glomerulonephritis.
Right.
So class 4 diffuse proliferative global glomerulonephritis with more than 50% of the involved glomeruli having global lesions. And it seemed not to have arterial involvement or tubular interstitial involvement.
Right.
Before continuing to the case, I have a tiny little question for you both. If the biopsy had been done before, on as soon as she had that proteinuria, and if that biopsy would be a class 2, would you repeat the biopsy if 2 or 3 months later she had more severe pyramids, more proteinuria, more severe active? So I'm really presenting this question to you because in the clinical practice, we do have these kind of things. Like, we know the kidney is involved. We have a class 2 glomerulonephritis, and then it gets worse. And it's really, really difficult to do another biopsy that just documents what we think is happening, going to 3 or 4, and the treatment is different. So what would be your practice in a case like this? If we had a first, and then she developed like this in a couple of weeks. Mario, you want to start?
No, I could start. So my big problem with that would be my nephrologist. They would say to me, this patient has now progressed to a 3 or 4. because the urinary findings seem to indicate that, and let's adjust her therapy and not repeat the biopsy at this time. My own preference would have been to document that, to do the second biopsy and see that there has indeed been a transition to class 3 or 4. But my big obstacle, and I don't say this in a pejorative sense, that's their opinion, that, that they would say, look, this is now transitioned. You don't need a biopsy to prove that. Let's just intensify our therapy.
David.
Yeah, I too, I'm what I would describe as a tissue man or tissue person, perhaps I should say. And,
Yeah.
I think my instinct would be very much along Murray's lines. I think I would like to do it, but the reality is that it's not going to happen for the reasons that Murray set out, that most people on the nephrology side would simply say to them, look, why don't you treat them a little bit more aggressively, see if you can get it under better control by upping your mycophenolate, by switching from mycophenolate to cyclophosphamide, whatever it is you think you've been doing, try something slightly different. And I suppose, given the fact that you have to say renal biopsy will be under ultrasound is much safer than it used to be in the old days. Clearly, there are problems, there are complications, even with biopsies done under ultrasound. So it's not a procedure which has no side effects. So I think pragmatically, you'd have to say that it would require a change in therapy and upgrading of the therapy to get better control of the disease, and only then, after probably more like 6 months to a year, I think, could you really persuade your nephrologist to actually go in and do another biopsy?
Thank you. Let's just go back to reality and to the case. And this patient had a kidney biopsy that confirmed type 4 glomerulonephritis. And she was started on increasing mycophenolate dose to 3 grams a day for induction, and prednisolone was tapered to 7.5 milligrams a day at 6 months. And after 4 months, there was still hematuria, but no red cell casts. The proteinuria was 1.1 gram per 24 hours, and her serum creatinine had come down to 120 micrograms millimole, and she was rediscussed between rheumatology and nephrology, and the choice was to add tacrolimus 2 milligrams a day to the management strategy. Murray, how confident are you on this treatment back then? And with the new ACR guidelines for lupus nephritis, would you change the approach?
Yes, thank you for giving me that out.
Would you rebiopsy?
No, I think, no, I probably would not. When I saw that biopsy now, this is a very significant biopsy, and the fact that it didn't respond in 4 months on prednisone and mycophenolate alone doesn't surprise me. And if you go with the new ACR guidelines, you would say the first thing you would say is, naughty person, why didn't you use triple therapy right at the beginning? And now that you didn't use triple, you only use dual, why don't you increase the triple? So yes, we were going to increase the triple therapy, hydroxychloroquine, mycophenolate, and now tacrolimus. The question, as a calcineurin inhibitor, nowadays, whether I would use tacrolimus or, if I could get it, voclosporin, maybe a better calcineurin inhibitor, but using additional therapy. So she would have at least triple therapy on board, I think is the way to go. And if I had to relive the scenario, I would have done it earlier. When she first had the proteinuria, I would have started triple therapy. The reason I really appreciate that, I know my good friend Brad Rovan, the nephrologist, who's really a rheumatology nephrologist, is always yelling at me, "Don't waste time, you're losing nephrons." And I think that's correct. It's if you let it go too long, you've given up a little bit of your kidney function. So I would have done it earlier than this now, adding the third drug.
David, having signs of ongoing lupus nephritis activity after 4 months, would you rebiopsy, or would you switch treatment or add treatment?
I would add treatment. I think these guidelines lay great emphasis on the fact that as we see in the early treatment of rheumatoid arthritis, once upon a time rheumatologists would give a single drug. We now, as a standard, would start patients on 3. So I think with lupus nephritis, people will now accept the fact, or coming to accept the fact, that a single or even two drugs is not going to be enough, especially with a type 4. I want to emphasize the importance of the type 4s. We've done long-term follow-up studies, 40 years follow-up studies, showing that the patients who do the worst by a long way are the diffuse proliferative patients. So those are the ones you want to worry about. And also, although it's not the issue here, just to highlight the fact that we do a dipstick test on every single patient on every single occasion, even the patients who've had their disease for 5, 10, 15 years. We wrote up a little study last year identifying 10 patients who'd had their lupus for 15 years before they got the nephritis. So it's one of those things that you can't say it's over till it's over, as it were. And so you have to be very mindful of this. But in this particular case, no, I think you want to up the ante, treat more aggressively, treat faster, treat with more drugs. And the voclosporin versus tacrolimus story is, I think, as much a financial one as anything else. In the States, voclosporin is still incredibly expensive, I believe. Murray can probably confirm this, but when I looked into this about a year or so ago, it was $90,000 per patient per year, which is astonishing. Tacrolimus, by contrast, is peanuts. It's very cheap. So my own nephrologists are quite keen to go with the tacrolimus first, but are beginning to use a little bit more voclosporin, I notice, though they tell me they still haven't been as impressed as they had hoped that they might be. So more treatment, more drugs, faster treatment. With active lupus, as Maria says, you mustn't mess around. You just get in there, get the treatment going as fast as possible.
Murray, we are talking about the new ACR guidelines for lupus nephritis, but not long before that, the KidGO 2023 also published guidelines, and there are some differences. What do you think are the clinical relevant differences between the KidGO guidelines and the ACR lupus nephritis guidelines?
Well, I think, the KidGO guidelines, they now have a 2024 edition, and I think they're a little bit more congruent. And one thing that I saw difference was duration of therapy. That the old recommendation from the kidney organization was, well, first of all, it was 36 months, and then it was less, or they weren't very clear. And you know that the ACR guidelines were, even when you are in complete remission, you maintain your therapy for 3 to 5 years. And the new 2024 KDIGO guidelines also say a minimum treatment of 3 years. So I think the maintenance therapy is now coming into line with all organizations, because even when we think, and some of those wonderful rebiopsy studies which showed that we thought we had cured this patient show persistently active disease, and so you don't mess around with it. Let's we keep the maintenance therapy for prolonged periods. And by the way, this was my other big fight with my nephrologist. They kept on saying, "Why are you keeping people on drugs? You're going to give them infections, etc., etc." And now finally, I can point to the ACR guidelines to say, "See, other people feel the same. Keep them on longer and watch carefully, obviously."
So, David, you would choose a B-cell depleting agent, probably with all the experience you have with rituximab. And after the publication of the phase 3 trial, regency of obinutuzumab in lupus nephritis, and the good results you had, are you still going to prefer rituximab, or are you moving on lupus nephritis just straightforward to obinutuzumab?
Well, sadly, we can't do that in the UK because it's not NICE approved, and NICE is the king here. NICE sometimes is not so nice, as you know. We are hoping this year that the FDA will give approval to the use of this fully humanized approach, and I think once they have pronounced it sort of piles a lot more pressure on NICE to give their approval too. So I'm hoping that that's what will happen. And as I've indicated, we do have permission in the UK, or in our hospital, to treat patients at the time of the diagnosis. So I certainly treated a number of patients with lupus nephritis. In fact, again, quite by chance this morning, I saw a patient who's actually a physician herself, a general practitioner, who presented quite late, actually at 40, with type 4 glomerulonephritis, which we did biopsy pretty quickly. She's been treated with rituximab. She had mycophenolate for about 3 years. She had hydroxychloroquine for 3 years. We eased off the mycophenolate in the 4th year and have now stopped that. She didn't want to carry on with hydroxychloroquine, which is now about 46, 47, I think. And she's not had any oral steroids, so Murray will be pleased about that, I think. So it is possible to treat even lupus nephritis, even type 4s, without using oral steroids. It can be done, and Liz Lightstone will tell you similar sorts of stories. So then, of course, perhaps I just mentioned en passant the hot new treatment, which is, of course, CAR T cells, which have been given to a small number of patients with eventually lupus nephritis. Most centres, I think, around the world where we have good oncology and good rheumatology are starting to do this. We've just entered our 5th patient into some CAR T cell trials, and we're waiting to see what will happen. Very early days, no disaster so far, so that's good. We don't obviously have George Schett's 4-year follow-up in some of his patients, which looks very encouraging. But worthwhile pointing out that one of the, if you like, the selling points that George Schett and his colleagues in Erlangen put forward is the fact that after 3 months, 4 months, they were able to stop all the lupus treatment, and that up to 4 years later, these patients remained in clinical remission. And importantly, the lupus antibodies had not come back. Now, you can see this occasionally, and this patient I saw this morning is a good example of that. It took longer, it's true, but this patient has been serologically in remission for the best part of 4 to 5 years now. After about 1 year, her DNA binding went back to normal, C3 was normalized. So you can get a very good result with these slightly older treatments. And obviously CAR T cell therapy is very expensive, very much more demanding of the patient. And my suspicion is it will be, unless it becomes much cheaper, much easier to give it, it probably isn't going to be widely available because of the necessary expertise. But it opens a new chapter, potential chapter, as of course, as we've discussed before, Raquel, the potential use of these bi- and tri-specific monoclonal antibodies which can bind to B and T cells. Very exciting time in not just lupus nephritis, but lupus in general.
Thank you, David.
And malignancy.
Absolutely.
Yeah, and malignancy. That's absolutely amazing. So currently, we have belimumab heading to mycophenolate or cyclophosphamide, voclosporin to HER2 MMF on lupus nephritis as a first-line triple therapy headed to steroids. And we also have the probability of having approved obinutuzumab to be used also on first-line triple therapy. So, and coming back to the first case where we discussed, of course, everything else that is added, like controlling the risk factors for cardiovascular, preserving kidney function, everything is there. And we have so much to think about when we are treating these patients. So, Murray, any final comments on lupus nephritis as it goes in 2025?
Well, first, let me agree with David that I think we're on the brink of something very special, but we're a far ways off, And I think when we can do the CAR T cell therapy with, homologous instead of autologous T cells, when you can store your T cells in bunches, not have to put, do leukapheresis in people for. Anyway, I think it'll become cheaper. And if the safety story remains positive, then I think it's a very exciting time. In terms of the current therapies, tacrolimus is a great drug, but you have to get blood levels, you have to monitor it very carefully. I'm hoping that voclosporin will be approved. I agree with David. And then once it's approved, I'm hoping to say the payers will pay for it, because it's cheaper than it will be much more expensive than tacrolimus, but it will be much more convenient for the patient. It'll be a pill. They don't have to come in and get their blood levels measured, et cetera, et cetera. So, we're on the brink of a small step like obinutuzumab, et cetera, and then a big step like the T-cell therapies and in the future. So these are very exciting times.
David, any final comments?
Well, I will say one nice thing about NICE, which is that NICE was set up about 20, 25 years ago in the UK with a very simple remit. It was not there to decide whether or not a drug was effective, but whether they deemed it to be cost effective. And what they have done is to drive down the cost of drugs. So Benlysta, for example, in the UK is a third the cost of the drug in the States. And the same with voclosporin, which I think is about a sixth the cost. So it's very interesting. But there's a downside to that, which is that other companies have been rather slow to take their products to NICE because they're worried that NICE will say, well, all right, your drug is okay, but it's not that great. Make it a lot cheaper. We'll be more inclined to reward you with license to use it. So it's a slightly two-edged weapon, but certainly in the case of voclosporin and in the case of Benlysta, we have these drugs officially available to use now and at a cost which is much, much more affordable for the country, and that's really not a bad thing. I think I just reiterate really what Murray has said. We are, and in fact, what I said, we're living in very exciting times. And I think the next decade, let's make it a decade because I think it will be that, we'll see some really fantastic advances. I think we're on the brink of that. And it would be nice to think that, in about 10 years' time, the drugs that we've been discussing today will be widely available. They'll be much cheaper, I'm quite sure, and that we'll be able to treat aggressive, nasty diseases like lupus nephritis much faster, much more effectively, and get the patients off the treatment, minimize the steroids, and though the overall outlook for these patients will be so much better.
Thank you so much. David and Murray, thank you for joining me today and sharing your insights into these two challenging cases from your clinics. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. To send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.